Our next speaker, who, as I said at the end, although interrupted by applause, Professor Farrow really teed up nicely, is Farr Curlin, who's the Josiah Trent Professor of Medical Humanities in the Trent Center for Bioethics, Humanities, and History of Medicine, and co-director of the Theology, Medicine, and Culture Initiative at the Duke Divinity School. I'll use this when you set up the slides. He was our colleague here at Chicago before we lost him to Duke in 2014, where he was the co-director and founder of the program of Medicine and Religion here at the University of Chicago. At Duke, Dr. Curlin practices palliative medicine and works with colleagues in the Trent Center and the Divinity School to develop opportunities for education and scholarship at the intersection of theology, medicine, and culture. He's authored more than 100 articles and book chapters dealing with the moral and spiritual dimensions of medical practice. His work focuses on the relevance of religious ideas and practices for the doctor-patient relationship, the moral and professional formation of clinicians, and care for patients at the end of life, which is what he does clinically as a palliative care physician. So please join me in welcoming Dr. Farr Curlin to talk about palliative sedation, clinical facts, and ethical questions.
Thank you, Dan. In his book, Dying Well, Peace and Possibilities at the End of Life, Ira Byock, a seasoned hospice physician, describes the painful case of Terry Matthews. Terry was a 24-year-old mother of a toddler when she was diagnosed with advanced kidney cancer. Intensive medical treatment kept the cancer at bay for 6 years, but then it returned with a vengeance, spreading to her lungs, her face, and sinuses, her shoulder, and multiple other parts of her skeleton. Over the ensuing months, Dr. Byock worked with Terry's oncologist, Dr. Stevens, along with Terry and her family, to relieve Terry's severe and refractory pain and distress. Despite deploying state-of-the-art treatment, high doses of continuous intravenous narcotics and benzodiazepines, the most common form of what we call sedatives, Dr. Byock and Stevens failed. Terry's pain persisted and became progressively more severe. In her final weeks, she appeared to suffer unrelenting anguish. Ultimately, Dr. Byock invoked a sedation protocol designed for just such a case, one in which conventional medical interventions failed to relieve the patient's severe suffering. After seeking consent from Terry and her family, Dr. Byock infused a different class of potent sedative until Terry was rendered unconscious. The sedative was continued until Terry died a few days later. This case of Terry Matthews provides a helpful window into the clinical context of ethical questions raised by the practice of sedating patients who are dying. The case is helpful in the first instance because the story is clinically detailed and realistic. Although Terry's case was exceedingly rare in the fact that high doses of conventional treatments did not relieve her symptoms, her suffering represents one pole in a spectrum of pain that becomes difficult to manage without using medications that render the patient intentionally or unintentionally unconscious. The case is helpful also because it brings out dimensions of human suffering that complicate medical efforts to relieve distressing symptoms, as well as the ethical tensions that conscientious practitioners will face as they seek to fulfill their obligations to patients. Finally, the case is helpful because it is described by a physician who, although he parrots some cultural assumptions that Christians have good reason to challenge, also joins Christian tradition in opposing suicide and euthanasia. At the outset, I note that ambiguity in terminology often obscures clinically and morally relevant distinctions between different clinical interventions that share in common the fact that they cause, whether directly or indirectly, intentionally or unintentionally, cause a reduction in the patient's level of consciousness. As it stands today, what Dr. Byock did to Terry Matthews might be described, depending on the observer, as effective pain relief, terminal sedation, sedation unto death, proportionate palliative sedation, or palliative sedation to unconsciousness. Some help in drawing these distinctions has been, the relevant distinctions between these has been provided by an unlikely source. Several years ago, some leading advocates for practices that come under the banner of physician aid in dying published an influential paper in which they put forward various, as they call it, last resort options in palliative care. Timothy Quill is the first author of this paper. And he's probably the best known physician advocate for assisted suicide. Pertinent to our discussion today, these physicians, these authors distinguished what they call proportionate palliative sedation from palliative sedation to unconsciousness. In the former, sedating medications are used only in doses needed to relieve pain, anxiety, or other distressing symptoms that accompany advanced illness. Although sedation is often accepted as a foreseen effect of such medications, it is not intended. And if a distressing symptom is relieved without causing sedation, so much the better. So defined, proportionate palliative sedation seems to satisfy the rule of double effect, and it has been universally defended by Christian ethicists, including the Roman Catholic magisterium. In palliative sedation to unconsciousness, by contrast, the physician aims to render the patient unconscious and keep them so until the patient dies. Unlike proportionate palliative sedation to unconsciousness has failed until and unless the patient is rendered and kept unconscious. So defined, palliative sedation to unconsciousness remains much more controversial than proportionate palliative sedation, particularly among Christians, and particularly when sedation is used to relieve fear of dying or other forms of what can be categorized as existential suffering. In a recent large study of U.S. physicians from specialties that care for many patients who died, colleagues and I found that 85% of physicians agreed that unconsciousness is an acceptable side effect of palliative sedation, but should not be directly intended. Are they right? Is this how Christians should think about consciousness? In what follows, I will explore the case of Terry Matthews in order to describe in more detail the clinical context in which these questions arise. I will then identify what seems to be at stake ethically, particularly for clinicians, for practitioners of medicine, by focusing on how different practices of sedation might align with or alternately contradict the goals of medicine. Finally, I'll propose briefly that what Dr. Byack did, despite initial appearances, is most reasonably described as proportionate palliative sedation, not palliative sedation to unconsciousness, and that Christians, and indeed all those concerned, sustain just practices of medicine toward those who are dying, particularly in our context, have good reason to support the former practice and oppose the latter. Now, in the paper, I spend the first third going over some of the physiological, clinical details of how pain works. In the interest of time, I'm going to skip past that, except to say that the case of Terry Matthews demonstrates what every clinician knows, and particularly those who care for dying patients. And that is that pain is variable, complicated, and often defies simple explanation as to its cause. Terry's pain was chronic. Chronic pain is different from acute pain that continues for a time. It takes on its own kind of particularly distressing character. Terry's pain was, at least in large part, neuropathic. Neuropathic pain, which is much less common than the more common nociceptive pain, which is caused by tissue injury. Neuropathic pain caused by disruption of the neurological system is characteristically more distressing, particularly when it, as was the case in her case, when it comes from the nervous system being directly invaded. She had tumors that invaded a nerve plexus in her shoulder, and it caused electric, jolting, seemingly capricious, but overwhelmingly intense recurrent pain. Neuropathic pain is also classically and characteristically highly resistant to the medications that are generally effective in treating more common nociceptive pain, particularly narcotics. her pain was also affected, as so many patients' pain is, by psychological and spiritual suffering. Byock noted, "I have no doubt that Terry's blinding grief at the thought of losing her husband and 3 young children contributed to her pain." More can be said there, but anybody who takes care of many patients with advanced illness knows that the way they experience pain is highly dependent on the overall context of their life and the kinds of psychological and spiritual suffering they are enduring. Moreover, Terry's pain, as is so often the case, was accompanied by suffering in her family, who Byock described as suffering a turmoil of grief and as overwhelmed by the chaos of their emotions. We'll see that that's quite important for the clinical situation in which the question of sedation comes up. Terry, Byock says, and her family never came to terms with the fact that she was dead. Had she been able to come to terms, my experience suggests, and his experience suggests, that it's likely that her pain would have been less distressing and less refractory to treatment. That's not to load the responsibility on her by any means, but it's just to observe that what we can roughly characterize as not ever coming to terms is usually accompanied by a more intense experience of pain. Now, let's dig into how sedation occurs. In the ordinary practice of medicine, clinicians intentionally suppress patients' consciousness when doing so makes it possible for the patient to endure an otherwise noxious medical intervention. Well, this is the most common way we suppress consciousness. Think about surgery or dental work. In such cases, sedation is part of an intervention to preserve or restore the patient's health, including the health that is expressed in normal consciousness. So if the person who is put under anesthesia does not wake up, that's a problem. At other times, clinicians intentionally sedate patients in order to treat a state of disordered consciousness. For example, people suffering from panic or other anxiety disorders are frequently treated with a class of sedatives called benzodiazepines. You might think of the very famous drugs Valium and Xanax, which are 2 prominent members of that class. And these are given in order to dampen a state of abnormally heightened, and to that extent, unhealthy consciousness. Long before the final sedating medications were given to Terry, she was treated with high doses of Valium for just this purpose, to mitigate the anxiety and distress that accompanied her experience of pain and her dread of leaving her family behind. Something similar is done when patients with agitation are treated with antipsychotic medications, or what commonly are called tranquilizers, to dampen that agitation. When these work, such sedation, such use of sedatives, restores patients to a form of consciousness that at least appears healthier, insofar as it's a state of consciousness in which the patient is better able to engage in ordinary human activities, like sitting up, talking, resting. Interestingly, it seems to me that even the sedation of anesthesia can be reasonably described as aiming to prevent the state of disordered consciousness that patients who undergo surgery would otherwise suffer. You can just imagine how many characteristic human activities you could engage in if someone had a scalpel in your belly and you didn't have anesthesia. That's not a state of health. At least it seems reasonable to me to think of it that way. This may provide an important analogy for characterizing what Dr. Byock did when he sedated Terry Matthews. An analogy for what we might think is a defensible and even laudatory use of sedatives. We'll turn to that question in a moment. In patients who are dying, clinicians less often intend sedation than they accept sedation as a side effect of medications used to relieve distressing symptoms. All narcotic pain medications cause sedation, but sedation is also caused by medications used to relieve including nausea, seizures, and delirium. To think of sedation as a side effect rather than part of the physician's intention aligns with the reality that suppressed consciousness is generally experienced as an undesired state. There's the obvious case of people not waking up after surgery. Everybody's going to freak out. That's obviously a disaster. But with respect to dying patients, people do not generally want their sensorium clouded, their capacity to think and communicate and engage in any life project blunted. Terry clearly experienced the sedation caused by pain medications as a loss. For months, Bioc tells us, she resisted increases in her pain medications, the doses of her pain medications, because they made her fuzzy or sleepy. Bioc notes that she feared sleep because it felt too close to death. In the end, however, relief of pain, excruciating pain, came to outweigh the cost of suppressing her level of consciousness. Bioc states, as Terry's story shows, sometimes pain is so severe and so resistant to customary medicines and therapies that a patient is forced to accept sedation as the cost of comfort. As Terry experienced, patients who receive these medications often develop tolerance to them. Clinically, tolerance is the condition of requiring higher doses of medication to achieve the same effect. It's extraordinarily common in palliative medicine, in any use of particularly narcotic medication. And it can often be overcome by increasing the dosage of medication. Terry's doctors attempted to control her pain and her anxiety in this way, increasing her intravenous narcotics and benzodiazepines stepwise to doses higher than I have ever seen in 8 years of practicing hospice medicine. Bioc accounted for these extraordinarily high doses as falling from, quote, a basic principle of palliative medicine. With severe pain, there is no maximum dose of pain medications. The right dose is the one that works. That seems true to me in a sense, but it would be truer to say, I think, that the right dose is the dose that works up to but not exceeding the point at which the adverse side effects of the medication come to outweigh its benefits for the particular patient in her particular situation. Now, that language I'm using there invokes the proportionality principle in the rule of double effect, a rubric which for centuries has helped physicians make practical judgments about when to use their various administrations, virtually all of which have adverse side effects. The rule of double effect will probably be unpacked more today. I'm not going to get into it in detail, except to say that it can be, I think, simplified to two basic conditions. One is willing or intending only the good effects of an action and an intervention, and there being proportionality, where proportionality includes not only using a dose that fits the symptoms being treated, but also includes all the relevant contextual features of the situation, including but not limited to the resources available, the prognosis, the patient's particular location. Critics of the rule of double effect, and there are many, a growing number in the contemporary world, sometimes suggest that it requires a kind of scrupulosity in which clinicians drag their feet and increase doses of medications by small increments at long intervals in order to avoid any possibility of adverse side effects. That's not the case. In cases such as Terry's, where the pain is severe and the prognosis is terrible, a clinician has good reason to escalate doses very rapidly and to accept substantial risks of side effects, even to accept side effects that are almost certain or certain. The clinician cannot, however, aim to injure or destroy the patient's health and still satisfy the rule of double effect, this norm that has been so central to the practice of medicine. So we face the question then, does a clinician who permanently suppresses a patient's consciousness thereby act against the patient's health? If so, is that action defensible on other grounds despite apparently violating the rule of double effect? Terry's story does show that there are cases, at least in theory, it's debatable whether hers was such a case, but in theory there are cases in which a patient's pain is resistant even to the most state-of-the-art therapies. In such cases, a clinician might do what Dr. Biok did for Terry. They might use medications that seem to relieve pain only by suppressing the consciousness that makes the experience of pain possible. More often than not, physicians achieve such sedation by using the same benzodiazepines that Terry was already receiving. In Terry's case, Dr. Biok used thiopentol, a drug that would normally only be used in anesthesia. Note that cases like Terry's are very rare. Biok writes that in 15 plus years of caring for dying patients, I have needed to resort to full sedation utilizing an infusion of barbiturate only once. Now those who today, in our context, seek for or advocate for palliative sedation to unconsciousness as a form of physician being in dying will often invoke a case like Terry's as the rationale. As is the case for those advocates for physician-assisted suicide, who can be against relief of unbearable and unending suffering? However, it's quite clear from the data from Oregon that both practices are used much more commonly to relieve a type of suffering that's quite distinct from the pain experienced by Terry. If a person is condemned to the gallows, we wouldn't be surprised if the person suffered fear, dread, regret, sadness, agony, soul. So also the one condemned to die from terminal disease. Moreover, the latter anticipate not only death, the end of everything they know, but also all of the losses and declines that the progression of their disease may bring before they die. And among those who have availed themselves of physician-assisted suicide in Oregon, few were worried about, much less experiencing uncontrolled pain. It's quite clear from the studies of the people who have undergone assisted suicide. Rather, the great majority have been like Brittany Maynard, who took her life with her doctor's assistance to avoid the decline in dependence she anticipated. Whereas assisted suicide aims at death as a means of avoiding unwanted suffering, palliative sedation of unconsciousness for existential suffering aims at unconsciousness as a means to avoid the same suffering. So how might we think of, I want to dig into what's at stake ethically, particularly for those who practice medicine in sedation. And just focus on how we might think of consciousness and sedation with respect to the traditional norms of medicine, in which medicine is a moral practice that has a rational end, namely health. In this traditional understanding, which it seems to me Christians throughout history have largely taken for granted, physicians should avoid practices that undermine or contradict the purpose of medicine. Principally, they should not act to injure a patient's health, much less to hasten the patient's death. Now, much ink has been spilled to describe the fact that this traditional orientation of medicine has largely been replaced in our context by an orientation in which medicine is construed as a morally neutral practice of deploying technologies on human bodies to minimize suffering and to maximize well-being according to the authentic wishes of the patient, and perhaps according to the needs and directives of other authorities such as the state or the insurer. How we came to this point is beyond the scope of this essay, but that we have arrived is clear, and nowhere more so than in the practices of what has come to be called palliative care. I've written about this elsewhere, but the palliative care community has, I regret, been sliding toward cutting itself off loose from medicine's traditional orientation to health. Health, it seems to many people, is too narrow a goal, too constraining. National and international palliative care organizations affirm broader goals for palliative care that, again, default more or less can be summarized and are quite explicit about this as minimizing suffering and maximizing quality of life, and doing so according to the wishes of the patient. Interestingly, Biock's account, accepting periods and cultural assumptions we have Christians, I think, have good reason to challenge, and this is a central one. He endorses and reflects this emphasis on patient choice and autonomy, writing, quote, "Terry's dying demonstrates that dying well is fundamentally about people experiencing something that has meaning and value for them." That, I don't think, is a particularly Christian idea, but it is an idea that resonates with contemporary culture's emphasis on individual authentic self-expression. And if it's true, then we have to ask, well, what if ending one's conscious experience is consistent with what one values, with how one wants to die? Gil Meilander, who's going to speak later, in his essay quotes Leon Kass, who's perhaps the most forceful and influential critic of modern expansions in the goals of medicine. He quotes Kass to note that even Kass supports the idea that treating suffering is a part of medicine's goals. Kass writes in the essay, "Relief of suffering stands next to health as a crucial part of the medical goal, and medicine has always sought to comfort where it cannot heal." Well, what can Kass mean here? Medicine, the relief of suffering stands next to health as a crucial part of the medical goal. What can he mean, and in what sense can this be true? It seems that our challenge as clinicians is to, at least in part, to discern how the relief of suffering is part of, or at least does not contradict, the purposes of medicine. Note that Kass is enigmatic. I find it enigmatic, and actually went and talked with Leon Kass face-to-face about it last week. His enigmatic quotation comes after an entire chapter in which he argues that health, period, is the constituent goal of medicine, and that health must be defined as an objective bodily norm. In that chapter, after carefully working through what we can know about health, Kass defines health as the well-working of the organism as a whole and an activity of the body in accordance with its specific excellences. He contrasts this definition with that of the World Health Organization, which defines health as a state of complete mental, physical, and social well-being. Kass argues this is wildly too expansive, and that's so much so that it has essentially no boundaries. The challenge is that people suffer all manner of burdens and wants and losses that medicine might treat, but we might wonder if medicine has any business treating. People suffer the lack of children. But does that imply that the purpose of medicine includes securing children for those who want them? People suffer today having sexual organs that do not match their gender identity. Does that imply that the purpose of medicine includes securing at least the appearance of sexual organs that do match the gender identity? More to the present point, many patients suffer consciousness of their impending decline and death from terminal illness. Does that mean that the ends of medicine include ending such consciousness? In what sense, then, do physicians reasonably aim as physicians to relieve suffering? Without positing illusory bright lines, I propose that physicians reasonably act to relieve suffering insofar as that suffering is generated by and contributes to insults to health. Health, Kass helpfully reminds us, is not merely the absence of disease. Rather, it is a positive quality, a capacity demonstrated in activity that's characteristic of the particular kind of being under consideration. The health of a squirrel is displayed differently than the health of a human because squirrels and humans have different characteristic activities. The activities of healthy human beings are highly varied, but they include, surely, being able to sleep at appropriate times, to sit and stand when desired, to eat and digest food, to move one's bowels, to concentrate one's attention on another. All of these activities are threatened and diminished by uncontrolled pain, breathlessness, and other distressing symptoms. And in that sense, the relief of such suffering is not in addition to the goal of health, but a central aspect of that goal. And there I think Cass should have revised the sentence that Gill quotes. We see this in Terry's story that when Biak notes that Dr. Stevens had wanted Terry to accept higher doses of medications in order, quote, to have a semblance of comfort and be able to function. So what about sedation of consciousness? It seems to me temporary sedation is almost always intended as a means to preserve or restore health. And that the health to be preserved and restored includes consciousness. Although the state of temporary sedation is different physiologically than sleep, both states can be conducive to health, including healthy consciousness. By contrast, a person who is rendered permanently unconscious is thereby rendered, all else being equal, less healthy than before. Indeed, consciousness is a necessary condition for all distinctively human activities. It's not to say condition for all human activities, but those activities that are distinctive of humans as opposed to other animals. And here I raise another caution from clinical experience. The central aim of palliative care today is comfort. That's the way people talk. And a person, we just want to make you comfortable. We just want this to be, we're focusing on comfort. A person who is sedated at least appears to be comfortable. The apparent comfort of the patient, however, is an illusion. The patient who is sedated to unconsciousness is not comfortable, not so much comfortable as they are in a state in which neither comfort nor discomfort can be experienced. The patient is existentially out of reach, incapable equally of discomfort and comfort. If we go all the way back to the Hippocratic Oath, I'm going to wrap up here in 5 minutes. Going all the way back to the Hippocratic Oath, physicians for centuries have promised to never give a deadly remedy to a patient, no matter how much implored. This profession reflects the enduring temptation to get rid of suffering by getting rid of the one who suffers. Watching people languish, even watching them hang on in the final days and weeks of terminal illness, is very difficult for family members. And you know what? It's difficult for their physicians. This difficulty is evidenced by the suffering of Terry's family and by Biak's description of what sedating her would accomplish. Biak noted that in Terry's final decline, her family suffered as much as Terry. Of Terry's husband, Biak writes, Paul had been warned that she might overdose, and at first he worried. Again, consciousness, consciousness generally perceived as a loss, but something we don't want to lose. First he worried, but when nothing quieted her screams and moans, he found himself wishing he could put her out of her misery with a massive rejection. When Biak administered the potent sedative, he told the family this: the 5-pentyl infusion will eliminate Terry's pain and give everyone some peace. After Terry was sedated, he said, peaceful quiet settled on the home. Bodies relaxed. Terry's quote, children finally saw their mom at peace. Terry's mother found rest, noting that her daughter was finally at peace. What I did not say, but which one can imagine, is that he and Dr. Stevens also felt more at peace. Certainly would resonate with my experience of taking care of many such patients. It was finally over. But insofar as the term at peace describes Terry, it describes her in the way that at peace describes someone who has died. Neither a person who is sedated nor a corpse is suffering. But neither are they experiencing what family members and physicians experience as peace. The worry, I think it goes back to Hippocrates, is that we will be, in attending to those who are dying, we will get into the temptation to do away with a patient's capacity to suffer in order to relieve our own suffering. Because the temptation to make suffering go away is part and parcel of caring for patients with advanced illness, physicians seem to have reasons to resist practices that aim at sedation of unconsciousness. In the end, it seems to me that what Dr. Biock did to Terry Matthews is better described as proportionate palliative sedation than as palliative sedation of unconsciousness. Yes, he used a medication, the primary action of which is to suppress consciousness. Yet it seems clear that he used that sedative in direct proportion to the signs of her pain and distress, not with the aim of making her unconscious. Biock writes, I carefully adjusted the medication upward to make sure there would be no more twitches, no more spasms of pain to jolt her awake. I discussed further changes in the 5-pentyl infusion rate with Ellen, the nurse, instructing her to regulate the rate to prevent the visible twitching of the left shoulder that had heralded such each explosion of pain. So he's watching carefully for, we see here all the markers of proportionate use of medication, titrated to treat the pain, not to achieve a certain level of consciousness. Or put another way, he sought to suppress her consciousness only insofar as necessary to relieve her distress and symptoms. Moreover, nonetheless, here I'm probably getting out on thinner ice, but I'm going to go. Insofar as it was titrated to signs of distress and signals of the pain that would jolt her awake, Dr. Biock's sedation might be construed reasonably, it seems to me, as oriented to a state of consciousness that is more healthy by virtue of being less disordered. This is a kind of extreme case. But had he achieved that state, less disorder of consciousness, without leading to unconsciousness, it seems clear to me from the story that he would have considered his treatment a success. He would not have continued to achieve full unconsciousness. Now, it's quite different from sedation that aims to make a person unconscious and keep them so until they die. A colleague recently told me of a friend of his who had advanced cancer and dreaded what he might experience in his final weeks and months of life. And in order to avoid that experience, the man who was in hospice arranged to be sedated to unconsciousness by his hospice physician. And he died more than 2 weeks later, most likely from the effects of dehydration. My colleague noted that he has never been able to come to terms with that decision by his friend. It felt like suicide, my colleague put it. And maybe that's overstating it, but it seems there's something about that seems right to me. It seems quite unlike the case of Terry Matthews. I suspect Dr. Biock himself would agree, given that he wrote, quote, people unfamiliar with the purposes of palliative care may see little difference between sedation to control persistent physical distress and euthanasia. What may appear philosophically to be a fine line is, in practice, a chasm. Of course, we're trying to get clarity about whether he was correct. Thank you.
Questions here? Yes.
Thank you, Dr. Merlin. Hello. Thank you for the enlightening presentation. Thank you very much. I have two questions. One relates to the concept of comfort that related to the
Concept of what?
Comfort.
Comfort.
Comfort. How do you think we can define comfort and how variable that is from society to society, the American society versus Romania, for example? Number one or two, patients with chronic pain that deals with neuropathic pain daily 8 out of 10 versus a patient with sinusitis. I think that's very variable from person, so I'd like to comment a little bit on that. Second is on relationship of conscience with the soul of the person. Do you believe that when the conscience is altered, how the soul behaves?
I'll just say the second question, I don't know. But I would seem compelling to me what Dr. Farrow described, which is, for Christian understanding of the soul and bodies, that you can't separate we're embodied beings. There's a distinction, but it's inseparable. And so I would not say that the soul is sort of somehow departing from the body when the person is unconscious. is also difficult. The word comfort is, it is, it's a fuzzy concept. And part of the challenge is the reality is that even pain is a fuzzy concept. Less fuzzy, but also fuzzy. And I don't think because of the subjective nature of pain and suffering, we can get to a precise, we can get concepts that don't admit of the kind of fuzzy lines and blurred lines that are just the reality of human experience. We'll say that people in the United States, which has about 5% of the world's population, that's right, 300 million out of 6 billion. Anyway, I can't do the math. But use more narcotics than the rest of the world put together. So, and I'm not actually being critical of that, but I think it should raise a flag of caution for us.
Hi, I just have a question. As a Christian clinician, it seems to me that, with all due respect to Hippocrates, we have so much technology, and we often use it to maybe continue suffering. I see it all the time at the hospital, where we have all these machines we can apply, and family and patients want everything done every day, forever. And then the opposite, I think that's just as morally disturbing as
What's the opposite?
Pardon me?
What's the opposite?
The opposite would be palliative sedation to the point of death. And so, I think that our technology is there to be used in positive ways, but palliative care isn't just to care, it's to symptom manage the best that I can tell. And so there's different ways to symptom manage that also makes you comfortable, but maybe not asleep or unconscious. But I struggle with how we define technology and how we use it on either end. And both ends seem to me morally distressing.
Yeah, that's a good point. Why does the idea of assisted suicide and sedation of conscience and aided dying become so pressing politically, culturally? I think in part because people are observing that the default pathway uses no technology to the point of inducing suffering far out of proportion to the benefit it provides in those last parts of life. But with due respect to Hippocrates, there's nothing about Hippocrates that requires that by any means whatsoever. Nor, the Christian community of clinicians began to use what was described as sort of the oath of Hippocrates insofar as a Christian may swear it. They rewrote it. They did pray to Apollo and Asclepius and Hygiene and Panacea. But the fact that it was so adopted and disseminated among the community, I think reflects the way that insight was one that cohered with the way Christians make faithful use of medicine in their own communities. And that is, they didn't make it, it was not, St. Basil makes this quite clear. Faithful use is not doing everything you can with all available technologies and making your life, as he puts it, one long provision for the flesh. It means using it when it's reasonable to use it, according to your vocation, depending on the situation, not putting too much confidence in it, and trusting yourself to it too much.
According to you, what is the most important question, ethical question, as far as intimacy is concerned?
As far as what is concerned?
Intimacy, birth.
I guess I'm with, as Dan said at the outset, with respect to euthanasia, I don't have any questions. I think it's clear, euthanasia is clearly making the patient's death your goal, and that is not permitted if you think it is unethical to intentionally kill, particularly to intentionally kill the innocent.
How would you characterize palliative sedation? Is it a specialist technique? Is it a kind of care arrangement that you should leave to specialists? Can it be done also in general practice?
In what practice?
In general practice?
Yeah, no, I don't think it's, the technology is quite simple. Certainly experience gives you more, with experience you come to have, of all things, a better grasp on what the effects of what you're using are going to are going to be and how to approximate or proportion the drugs you're using to the symptoms of the patient. I think the critical thing for me is to use language that clarifies the relevant distinctions. So I once had a long email exchange with the director, the head of legal affairs for Compassionate Choices, who expressed outrage that our study showed. She thought I shared her outrage initially, which I didn't, but that there were many doctors who wouldn't sedate patients to unconsciousness intentionally. She said this is outrageous because, paradoxically she said this, because palliative sedation is widely accepted. Everybody is for palliative sedation. All the major organizations have affirmed it. It's good. The problem is palliative sedation is lumping two practices, one which the Roman Catholic Magisterium endorses, and along with practices which it certainly doesn't endorse. And so we have to drill down those distinctions, but technically it's not complicated at all. Anybody can do it.
With the many different understandings of health and traditional medicine, what had a name of health, and now we have a newer understanding in our culture of what the aim is more individuals and quality life, that sort of thing. And your own work has shown that a doctor's own religious understandings impact their care.
Yes.
What do you feel the role of the doctor's religious understandings and their moral convictions should be vis-a-vis the Catholic Church?
That's a good question. It's not by accident that the profession of medicine has been held as an exalted profession, as an honored profession across many different world communities. That it came into being, for example, in the United States, despite it being as then as now, although perhaps more now, a lot of disagreements about a lot of important moral questions. It's so insofar as medicine is practiced with an orientation to health, as Cass defines objectively, something less than that state of affairs that I might want at a given time that has to do with my body. It seems to me that Christians bear witness to it as people who are bearing witness to something that should be available, reasonably available for everyone to see. That this is not Christian medicine, this is just medicine, good medicine. That doesn't mean there aren't some details and places where the practice of a physician practicing good medicine, one physician practicing good medicine might differ somewhat with another practicing good medicine, and particularly depending on who their patient is. So you can imagine, in the way that the person's vocation rightly structures the extent to which they should seek medical help and which kinds of medical help they're going to cooperate with, attention to that vocation will lead to different kinds of uses of technology. And you can imagine that a physician who has a sense that the vocation of every human being is toward God, it's going from God, we're wayfarers on our way to God, will just have a different kind of imagination that will probably lead, to some extent, to different choices that come out of their interaction with patients. I don't think you can escape that, and nor should we try to. As long as the practice is still congruent with the ends of medicine.
Just, all right, last question.
Yes, I'd like to follow up on that. It seems clear that the physician is fairly limited in their ability to help the patient come to terms. And the example you gave of the 16 case, part of the experience of being was based on the ability to come to terms with the diagnosis. Are there studies or is there evidence that patients less often opt for elucidation from consciousness if they have a chaplain or someone else who's supposed to be serving the role of the health consultant?
It's a great question. To my knowledge, no. There is evidence. I don't think the study's been done quite like that. there is evidence that among patients who are critically ill with advanced cancer, those who say they receive their spiritual support from the medical community, including the chaplains, are more likely to opt for hospice and more likely to decline life-sustaining technology at the end of life, compared to those who say they receive their spiritual care from their religious community. It's quite an intriguing finding. I think it should stir Christians some soul-searching and perplexity and trying to understand why that's the case and to what extent that might be problematic. But that is the case.
Well, please join me in thanking Dr. Curran.